We can start, so thank you.
Yeah. So before I start at the outset, as Janish sir mentioned, I am actually presently working in the Government Medical College Trivandrum, right across the road. And we've started the IR unit since about 3 years now, and are routinely doing cases predominantly peripheral, neuro cases limited mainly to ECA, and the ones that do not in general require anesthesia. So in today's session, I know this is towards the fag end of Saturday, the academic day, and it would be harsh on you to actually take you through the theoretical aspects of many of these cases. So I'll keep it light and hopefully one or two points of at least each of the cases, and largely on how I have performed these cases probably will be the learning point, I believe. So we'll start off with one of the endocrine cases, a case of adrenal venous sampling. The outset also feel free to interrupt me in between so that if you have any queries either in between or towards the end, feel free to ask me the same at your convenience. So anyway, AVS is generally done in patients with primary hyperaldosteronism. Now this accounts for a minority of cases as a etiology for hypertension. And in general, unilateral aldosterone producing adenoma are the one of the important causes, in addition to bilateral adrenal hyperplasia and even idiopathic hyperaldosteronism. Now, treatment of this differs substantially depending upon the etiology, and therefore it is important that you establish what is the exact source of secretion of aldosterone in order to decide on treatment, as well as decide if surgery will cure the patient. So conventional CT and MRI, the problem is that you probably might be able to detect an adenoma, but it's found that around 30 to 40% of your adenomas may be non-secreting and may be actually incidental. And removal of that adenoma will not suffice to clinical improvement in the hypertension of the patient. And therefore, it is vital and important that you sample the vein from the adrenal to identify actually what is the source of your autonomous aldosterone production. So the issues with AVS and how we perform it in our institute is what I will highlight with this case. So this is this was a case of a 42-year-old male who had history of persistent uncontrolled hypertension on for about 10 years and was on about 10 antihypertensives. After the initial evaluation, including your renal artery Doppler, all vascular causes were ruled out. It was found that the endocrine evaluation, that the aldosterone-renin ratio was elevated, which was diagnostic of a primary hyperaldosteronism. The confirmatory test was done and CT was done as part of evaluation that incidentally showed a left adrenal body thickening, suggestive of possibly an adenoma. The right adrenal was normal. Now, before, because the patient already had uncontrolled hypertension on 5 antihypertensives for about 10 years, and an adenoma on one side, before proceeding for surgery to remove the same, AVS was considered to evaluate the clinical response post-surgery. So this was the initial CT venous phase that shows the small adenoma thickening in the left adrenal gland. So if you see carefully, what we generally plan on doing is basically trace the adrenal vein. So this is the location of the left adrenal vein that starts from the body and then joins into the left renal vein. This was the right adrenal gland that was normal. Now, the indication for AVS is that patients who are biochemically confirmed to have hyperaldosteronism and who require lateralization on which adenoma to be, which adrenal to be removed via surgery. And in general, the contraindications are related only if there is uncontrolled hypertension, significant ischemic heart disease, any bleeding issues, or allergy to contrast, all of which has now remedial measures that can be taken before your AVS. So before we do, generally you have to withhold all aldosterone antagonists that your patient is put on. anticoagulants has to be stopped. Also, your CT imaging has to be reviewed as to the location of the adrenal vein. So this is the left renal vein. The left adrenal vein can be readily seen in all CTs. In general, you have, this is the left phrenic and adrenal trunk that will further divide into a phrenic vein as well as the left adrenal vein. Forms a V that I'll show in the angio. The right adrenal on the other adrenal vein, on the other hand, is very difficult to be delineated. You'll just see a small continuation right from the IVC. It will be almost flush with the adrenal body and the IVC. So it's very difficult to be clearly delineated, but that connection from the IVC can be depicted, on which you need to look at the vertebral level. And whenever you're doing your angios, you do it according more or less depending upon the vertebral level where you have seen in CT. So you start searching it one level above the one that is seen in CT. So this is how we generally do. In initial, I think around five or six cases that we did with stimulation, that is cosentropin stimulation is given about 30 minutes before the procedure. And this procedure has to be done as the first case in the morning. So we usually start at 8 o'clock. We started with cosentropin infusion. And after 30 minutes, with the infusion continuously running, we take up the patient for the sampling. Over the last, I think around 3 or 4 months now, the cosentropin was not available in entire South India. And we have shifted to the non-stimulated test. But now there is another alternative because of which we have now reverted to the stimulation test. So whatever test we do, generally what we do is we take a bilateral CFV axis. So in both the common femoral veins, we have placed a 5 French sheath bilaterally. And initially we keep one catheter. So we keep a straight vertebral glide catheter from the left axis into the IVC. This is to take the peripheral sample from the IVC in the infrarenal vein level. So generally, I think many institutes take the sample directly from the sheath axis itself, which is also enough as per literature. But in our institute, we follow the protocol wherein we take a sample right from the IVC below its junction of the renal vein. With that in place, from the right side, initially we go ahead and cannulate the left side. So this is the initial cannulation we have done with the Cobra catheter, wherein we pass the Cobra and then distally we have passed the wire. So once we generally use a short Cobra, and once if there is any difficulty with the Cobra to hook into the adrenal vein, we shift to a burn catheter. So this is the angiogram that shows the phrenico-adrenal trunk. This is a common trunk. So further, we have to go selectively to cannulate the trunk. So this is, we have actually exchanged for a burn catheter. Now with the burn catheter, we have actually entered into the trunk, and this is the initial angiogram that shows the Y-like configuration of the trunk. So the one that goes medially and superiorly is the phrenic vein, and the one laterally that goes is the adrenal vein. In general, it is not necessary as per studies that you need not go selectively into the adrenal vein. Getting a sample from this part, this location is more than enough. You should never actually take a sample near the renal vein or into the renal vein. That's the only importance. Many centers do selectively cannulate using a microcatheter. The difficulty is that your aspirate may not be good because the vein usually is very small and it may collapse. Now, cannulating the left adrenal vein and taking the sample is relatively easy, and that's not the most difficult part. The most time-consuming and the most difficult part is actually cannulation of the right adrenal vein. So generally, from the very little experience that we have here, generally what we rely on mostly is the shepherd hook catheter. We are not actually getting it from our vendors that much. So we have a shepherd hook catheter which is ETO'd and reused in many of our patients whenever it becomes available. But our alternative is either SIM1 or, if not going with that, Cobra. So this patient we have actually tried with the shepherd hook catheter, and as I said, you look at the level of the adrenal vein in the CT. So if it is at around D12, you start trying to hook it from around D11 inferiorly in that direction. Sometimes the origin may be slightly posterior. So if you want, you can actually take a lateral view and confirm whether the tip is directed slightly posteriorly. Also, in general, if you're not seeing a accessory inferior hepatic vein, generally cannulation of the right adrenal is found to be relatively easy, and by itself it would go. Now, this is the one that is hooked into the right adrenal vein, and the angio that is showing the right adrenal vein configuration. Now, the problem with right adrenal vein is generally both the catheters that we have used are 4 French catheters. 5 French catheters are very difficult to hook in general. Even if you are hooking with a 5 French catheter, you are unlikely to get any aspirate because this vein will go into spasm. You will not get a sample. Also, the thing to be ensured is that when you're injecting also, you need to inject very slowly because the vein is very small, fragile, it may rupture and your sampling may not be possible. Now, so this is the shepherd hook catheter that we use in general to enhance the aspirate that is coming through the catheter. It is better that you use the flush aortogram like catheters which have a side hole also at the tip. So the shepherd hook comes with this, the Cobra SIM and all, which is available with Merit, which we commonly use, do not have. I think Cook also has a SIM which has side holes, but not generally readily available on our shelf. So if this hole is not available, what we generally do is we take a normal 4 French catheter and then we'll plunge a hole with a 16 gauge needle at the tip before introducing it. Now, this is how generally we collect the samples. So the samples are collected in EDTA bottles. So once we cannulate the left adrenal vein, we take around 2 ml in one bottle that is for assessment of cortisol. Another bottle we collect for aldosterone. Similarly, from IVC, we take only one sample, that is a sample for cortisol. The intention of taking it from IVC is just to confirm that our cannulation is correct and to confirm that it is actually from adrenal vein. So the right adrenal vein, again, similarly, we take 2 samples, one for cortisol assessment, the other for aldosterone. Similarly, at the same time, we are taking from the IVC for cortisol assessment. So in general, the cortisol assessment is generally to confirm that whatever sample we have taken is a good sample that has come directly from the adrenal vein. That is only for confirmation. The aldosterone is the one that we are actually concerned with regard to your clinical assessment in general. So now there are 2 values or indices that are important. One is actually the selectivity index. Now the selectivity index is basically you have the right selectivity index and the left selectivity index. So as I said, what we are assessing is cortisol values that we have taken from the apparent adrenal vein and what we have got from IVC. So this ratio will, if it is more than 5, that means the cortisol level from the adrenal vein sample should be very high in general. That means that you have taken it correctly. If there is any contamination from the renal vein level, this ratio will not meet its cutoff. And that means that you need to repeat your adrenal vein sampling. Now, this results will come within about 2 or 3 hours. So in the morning, if you are doing, by afternoon, you will get the results. So if needed, if at all there is any wrong sampling, you can consider repeating this procedure the next day. You generally you do not do it the same day. Then once that sample is confirmed, you need to do lateralization index, that is which adrenal is actually secreting the hormone. So that is based on this value or ratio between your aldosterone and cortisol. So generally, if it is an adenoma, generally the ratio will be more than 4. And if it is hyperplasia, it will be less than 3, meaning if it is unilaterally, one side is going to produce more. Naturally, it is going to be from adenoma, or that is a location for the side of the adrenal from where it is being secreted. If it is less, that means both sides are almost equally secreting. That means the ratio will come down. That means both the adrenal glands are going to secrete, in which case removal of both adrenals cannot be done. So the patient should be continued on no other options but medical treatment. But if you get this pattern, that means that that side adrenal gland, if removed, the likelihood of the patient's hyperaldosteronism responding is very high. So in this particular patient, we got these values. The selectivity index on the right side was 9.85. So it's more than 5, meaning the right side sample was adequate. Similarly, on the left side, this were the samples. So on the left side also, the sample was found to be adequate. Now, this we come to know of in the same day. The aldosterone values actually come about 7 to 10 days later. And the values are correlated to the lateralization index in this particular patient that came to around 0.73. That means both the adrenal glands are secreting, though in CT you are seeing a thickening in the left adrenal gland, which means that this patient is not going to respond with surgery and should be continued on medical management. Okay, so for detailed reading, I think articles references are already known to most residents, which you can do it later. So next, I think portal vein embolization as a case was already presented, I think last week. So this is mainly a portal vein embolization case that has a cardiac interesting feature. And I think my teachers would not forgive me if I do not present a cardiac case also. So this was a 50-year-old male who had a BMI of 38. He was obese. He was actually a non-alcoholic, and on ultrasound, he was detected to have a focal lesion in the right lobe of liver. Now, CT showed a segment 8 lesion that was showing arterial heterogeneous enhancement, which was persisting in the subsequent phases. In the central part, there was evidence of necrosis, this non-enhancing area. There was no definite washout, so our imaging diagnosis was primarily more in favor of either a adenoma or remote chance of a metastasis. So the metastatic workup in the rest of the patient did not find anything. So our working diagnosis in imaging wise was actually a hepatic adenoma. So for management, initially the patient underwent an FNA, which showed only hepatocytes, and they suggested correlation with biopsy. And then finally we did a biopsy as well. Now the biopsy actually came as suggestive of hepatic adenoma. However, because of very mature hepatocytes seen in the sample, they told that a remote possibility of a well-differentiated HCC could not be ruled out. Anyway, because the lesion was large in size, patient had pain, and this doubt whether it could be a well-differentiated HCC, surgery was planned by the surgical gastro team. And as was highlighted in the last meeting, the need for portal vein embolization because the patient was a candidate either for a right hepatectomy or more likely an extended right hepatectomy. So the volumes cutoffs of around at least 30, 40, 50 for normal liver, fatty liver, and cirrhosis was needed. So even for a right hepatectomy, the residual FLR from baseline was only borderline at 35%. Generally, our institute cutoff is around 30. So if a right hepatectomy patient can be taken up with this on a borderline, but our surgical gastro team deferred. They told patient is relatively not do this and then take up. So generally, the steps are as was discussed last week, and as is being done presently in Chitra as well. The only change that I'm doing in my practices, generally we are more used to the acoustic of Boston Scientific when compared to the NEF set. Both have similar components, so there is not much difference. The other difference is generally we use, I think, a sheath placed into the right portal vein once the sheath is placed. Now, what we have changed in our institute is actually we are doing the entire procedure with this sheath in situ. So this sheath will actually allow a 4 French catheter to go through. So generally, most of our procedures will do with this transition sheath within, and a 4 French sheath, depending. We have a SIM, Cobra, all VG, everything is available for 4 French, which will go through this, which will suffice as well. Generally, nowadays, we do not rely much on using the sheath per se. So this particular patient, as was detailed last week, we have gone ahead through the right axis and then embolized using blue. This was the blue cast. And this was the follow-up CT that showed hypertrophy of the left lobe. Now, this was the post-portal vein embolization 4-week FLR that the right hepatectomy FLR was 50%. The extended increased to 32.7. Eventually, the patient underwent a right hepatectomy. That middle hepatic vein was well away from the lesion. So they did only a right hepatectomy and no post-procedure issues. This was, I think, the first case of portal vein embolization, which we did around 3 years, I think around 1 month after I joined. The interesting part in this is actually this patient actually came to us this February, that is this year, February. Now, this patient had complaints of chest pain for which echo was done. He had BP fold as well. Yes. Just a minute. So this patient came with chest pain, breathlessness. So echo showed hemopericardium with cardiac tamponade. So the patient.
One patient came in OPD now, not patient, only bystander. They're saying PTBD tube is blocked. I've not seen the case yet.
So,
yes, I have not seen the case yet. But we have to call the patient also, sir. Okay.
The patient underwent an emergency pericardiocentesis, and then echo was done actually for evaluation of the hemopericardium. In echo, they did not see any underlying lesion. So if you see, this was the post-surgical liver as well that is seen. So CT was done. So CT showed the hemopericardium and a small heterogeneously enhancing soft tissue lesion sitting over the RV and LV insertion point in relation to the pericardium. So this is the delayed phase images that shows that the lesion is enhancing, as well as there was mild thickening and enhancement of the parietal pericardium as well. So because the patient had a history of, oh sorry, I forgot to tell, actually this patient underwent surgery, and interestingly the final HPR came back as hepatic melanoma actually. So our imaging suggestive of an adenoma, and the initial biopsy specimen giving a diagnosis of it being a hepatic adenoma bar and HCC. We were in for a surprise because the final HPR came as melanoma. IHC was done, and from our side, we were actually, it was very difficult for us to believe. And even from the surgical gastro also, they had a second opinion with the slide review also. That also confirmed it to be of a melanoma. So PET was also done, which showed no other areas of uptake. So the diagnosis was of a primary hepatic melanoma, which is very rare. And then the patient, because patient did not have any lesions anywhere in the body, patient was kept on follow-up, and then he presented with this 2 months back. MRI was also done. So this is the cine SSFP axial images that shows the well-defined lesion sitting in relation to the.
Minister is saying we need patient also.
So this is the soft tissue lesion in relation to
The
the
patient is admitted somewhere.
pericardium. So sitting over the
now only.
Sitting over the anterior wall of LV.
It is not last week case, no?
Sheetal, can you mute the phone?
Okay, so this was the lesion in the two-chamber view cine. These were the tissue imaging. So this is the T1 image that shows the soft tissue lesion to be slightly hyperintense. This is the T2 that shows the lesion to be hyperintense. This is short axis 4-chamber. And this is a stir image that shows the hyperintense lesion. So this was the first pass perfusion that shows the increased uptake. This is the immediate post-contrast that shows the central uptake of contrast. The delayed also showing the central part to be showing gadolinium enhancement. And this is the pericardium that is seen in the vibe images that is showing intense uptake suggestive of infiltration and involvement. This is the diffusion image also that shows diffusion restriction suggestive of a aggressive malignant lesion. So because of a history of melanoma, the working diagnosis was that of a melanoma metastasis to the peri. So generally, melanoma, mesothelioma, and mediastinal malignancies have high propensity for cardiac metastasis. Though if you are considering a single malignancy, probably lung cancer would be one of the most commonest tumors that we see. Pericardium is the most commonest site, and in general, you can have lymphatic spread or hematogenous spread. Lymphatic spread is more common in lung cancer, and generally they are more in relation to the epicardium. And hematogenous spread is more commonly with melanoma, and they are more commonly endocardial generally. So this patient actually succumbed to the disease just before surgery was planned, I think 2 weeks back. So next is case of a peritoneal inclusion cyst. So peritoneal inclusion cysts are actually secondary to adhesions in the peritoneal layers in relation to inflammation or surgeries or even endometriosis in relation to the pelvis. So generally they are an active exudate from the ovarian parenchyma, and surgical approach is very difficult because there are high chances of recurrence because of fluid secretion into a adhered layer of the peritoneum will continue to happen, and high chances of recurrence. So this was a 34-year-old female who was a second marriage. Patient did not have any children from the second marriage. She had a history of right ovariotomy and salpingotomy in 2016, and de-roofing done later due to the presence of a peritoneal inclusion cyst. And as was thought, there was a large peritoneal inclusion cyst that recurred when the patient was referred to our institute. So this was the MRI that was done that showed a large around 18 into 19 centimeter sized peritoneal inclusion cyst, largely covering the pelvis, extending towards the abdomen, almost above the umbilicus level. So the concerns in this patient to go for whether surgery or any other interventional management was one, the patient was a second marriage. The family was not completed. So already the patient had a history of a right ovariotomy, and ovarian reserve was an issue. And secondly, you needed to prevent infection. Now, surgery was deferred because this patient already had a history of surgery, already young. Again, a surgery was not preferred by the surgeons because again, a recurrence would be difficult, and already a surgery bed reopening is and doing a surgery is difficult. So our plan was actually to do sclerotherapy for the same. So what we did initially was, because of these concerns, whether we do not know how the ovarian reserve issues will respond, because in general in literature, all your sclerotherapy or majority of sclerotherapy for your peritoneal inclusion cyst is done mainly for patients who are in the perimenopausal or postmenopausal or patients who have actually completed family. So in this patient, because conceiving was a very important thing, we also were in a dilemma what to do. So anyway, because surgery was not deemed possible by the gynecologists and surgeons, what we did was initially we thought we'll just drain the peritoneal inclusion cyst to relieve the symptoms. So what we did was, under ultrasound guidance, we placed a 8 French Malicot catheter into the peritoneal inclusion cyst and then drained it completely, and we followed it up for any recollection. So the plan was, if there was any recollection, we would do sclerotherapy after explaining the concerns or the risks involved as a second sitting. So generally, so this was a patient. We have placed a Malicot catheter, 8 French, into the peritoneal inclusion cyst. We have drained the fluid completely and was on follow-up. But on follow-up, we found out that there was a recollection of fluid within the initial 10 days itself. So because there was recollection, then we had to proceed to do some procedure. So then we thought we'll proceed with sclerotherapy. Now the issue was which sclerosant to be used. Now, literature-wise, there are reports of use of alcohol. There are reports of povidone iodine, that is, or betadine, but usually 15% or 20% betadine is what is described in literature, because we were not getting 20%, 15 or 20% betadine. What we have used is basically a 5% povidone iodine. Now, why we chose this is because we do not know how alcohol or even the more common agent that we are using generally for our sclerosis therapy, cetrol or polydocanol, how it would behave on ovarian parenchyma. So we thought also because there is a risk of infection, betadine probably may be a better option, and we thought we'll do that. So we've with the catheter in situ, we have actually drained the fluid and we have instilled about 20 ml of povidone iodine, 5% into the cavity, and then kept the fluid in situ for about 10 minutes. And then we have catheter to an external drain. So as I said, there are reports with you as well. We also thought that anti-Mullerian hormone, using that in this patient probably will be a good indicator whether it had any issue on the parenchyma. So the initial AMH was around 1.9, the subfertile category. So this patient underwent for follow-up. So after 4 days, this was a status, and after about 1 week, the membranes and the fluid was completely drained. The patient, just before leaving the patient in 1 month, we took an MR. So there were few small loculi that was remaining, but the larger loculi uh, were not present in the follow-up till about I think 8 or 9 months. She has come back on follow-up and was had no issues. And her AMH, this is the AMH that was at 1.5 months, that showed no difference from the prior preliminary value. So just that sclerotherapy is a relatively safe procedure, and that you can use povidone iodine. Generally, more than 10% is what is described, but you can make use of these as well. And serum AMH probably is a good marker to look at ovarian reserve, especially in cases where we are doing interventions in relation to the ovary. Now, next is a case of a bronchocutaneous fistula. So again, bronchoplurocutaneous fistulas are very difficult to manage condition because they arise secondary to infections or multiple surgeries. So this was a case of a 36-year-old male who had a left side chest tumor way back in 98, for which he underwent surgery. He went on to have radiation for a recurrence later on, and then re-excision later with surgical site infection, for which they did a graft placement. However, that also was lost secondary to infection. Finally, he developed a peripheral bronchopleural fistula, and for which the patient was referred to us in our setup, to our institute. So at the time of presentation, the patient already had 3 openings in the skin surface, and the underlying lung as well as the pleural fistula could be seen. So this was a CT that showed that the peripheral apico-posterior bronchioles were actually opening into the pleural cavity and then directly into the skin through the skin openings. So because multiple surgeries, radiation, everything had been tried, and recurrence was issue, the options that could have been done were discussed in a multidisciplinary team. So the initial option, or probably the best option, would have been an open repair, but because of multiple surgeries and issues, open repair was deferred by CTVs. The second option was to place a bronchoscopy guided placement to occlude the bronchoplurocutaneous fistula from the inside. So the problem with regard to bronchoscopy is that already his aeration is limited because of the air leak from the peripheral bronchiole. So when keeping a bronchoscope through the trachea, that much surface area of your trachea or your aeration space is going to be lost because of placement of the bronchoscopy, and that may cause ventilation related issues to the patient. And therefore, an IR related approach of actually plug occlusion via the skin or the percutaneous approach was considered. And once this was tackled, the plan was to go ahead and do the chest wall flap reconstruction. So what we have used is the Vascular plug, because Ambulance has a mesh-like structure. So air leak may still happen was our concern. So what we used was ceravascular plug that has a PTFE membrane within. So also this has some titanium nitride coating that improves endoepithelialization, which we thought will also help in causing a closure. So we sized our plug. We had two plugs, one for this part, one for this part. So we thought we'll occlude this first, check for any air leak. If there is no air leak, we'll stop it at that. If there was any air leak after placement of plug here, we thought we'll keep one plug here because there was one small bronchiole from this branch that also we had a suspicion may be leaking. So I think it was around 8 mm was the diameter at this level. So we used a plug that was around 12 mm. So the patient was intubated and then this was the pre-procedure. So through the skin, we put some saline just to see the bubbling in the orifice through the peripheral bronchiole. And then through the skin, that through the opening in the lung surface, we have passed a small radial sheath wire. So this is basically a 1/4 wire, which we have passed into the bronchus. And then once the wire was in situ, we have passed a 6 French sheath into the peripheral bronchiole through the percutaneous approach. Now, once the sheath was in situ, we have confirmed actually at what location we are in with installation of around 1 ml of contrast agent. And then we have passed the plug through the sheath into the site of the left apico-posterior bronchiole. So this is the plug being pushed into the apico-posterior bronchiole. So this is the plug here. Now, before detaching, we had to confirm. So we have before detaching, we need to confirm the position. So we have actually just withdrawn the sheath a bit with the wire in situ and the plug in place. And then we have taken a 3D CT, which confirmed the location. Secondly, we needed to see whether there was no air leak. So what we have done is we have removed the sheath. We have withdrawn the sheath back over the wire that is attaching the plug, and then we have injected the saline through the percutaneous surface. So that initial bubbling that was there is not seen with this part. So we have asked the anesthetist to ventilate a bit more vigorously. So there was no bubbling. There was an arrest of this was the initial where there was bubbling. And this is at the end when there was no leak. Second thing that objectively we can tell there is no air leak is what is the tidal volume that is given by set by the anesthetist or by the anesthesia workstation into the patient. And what is the tidal volume that is the expiratory tidal volume. So this, if it matches with this value, that means that there is no air leak from anywhere. So this was 500. This is also around 500, meaning that post-procedure, there is no air leak. So once that was confirmed, we have detached the wire cable and the plug was left in situ. So literature is also describing many other techniques. Percutaneously under CT guidance, you can put in a chiba needle and then inject glue as one agent that can occlude. Also transcutaneous, that is like you do your tracheostomy through a small incision, you can put a catheter or a guide catheter through the trachea, through the bronchus, and then into the site, and then put a duct occluder or any occluding device. You can do a external negative pressure dressing in order to cause healing. Coils you can use transbronchially. And also this described procedure of an ultrasound guided autologous blood you are instilling using a chiba needle is actually also described. And incidentally, this is described or done by one of our Chitra alumni, Brijesh sir, who is presently working in Aster, Kochi. So this patient was discharged with no further leaks. The granulation tissue had regrown and the orifices have almost closed. There is one more skin opening that is left, which is pending for flap repair. So this as an option in selected cases can be an option as an interventional radiology option in bronchocutaneous fistula. Next, I'll take you through a case of a very difficult aortic arch aneurysm case. So this was a 42-year-old female who had all the comorbidities that we could think of. patient was already CKD on dialysis, and patient had a left upper limb AV fistula. So this patient actually had uncontrolled hypertension, and on top of that, patient went on to have infection and sepsis, for which patient was on treatment. Later on, patient presented with chest pain, and incidentally on echocardiogram, patient was detected to have pericardial effusion initially, which was stabbed from a hospital outside, that revealed it to be a serous colored fluid, but the culture came as an MRSA positive pericardial effusion. So for evaluation, the same CT was done outside. So this was initial CT that was done outside. So the CT actually showed the large relatively large aortic arch aneurysm that was seen almost opposite to the origin of the left subclavian artery, as well as the pericardial inflammation that was there. Now, the management issues with regard to this particular patient was that because the patient was already CKD, patient was already on dialysis, patient was having an evidence of MRSA pericarditis. Surgery as an option was turned down by many centers because of the underlying infection and the comorbidities, and because this was an aortic arch aneurysm that would require a total arch repair or a frozen trunk surgery. So the options of endovascular was discussed again in a multidisciplinary team. So because surgery as an option was deemed not possible at that particular time, we thought we'll consider an endovascular as an option, at least as a bridge to a definitive surgery. And the timing of surgery was the second concern, because we already had an MRSA pericarditis proven. So keeping a stent graft into an infected bed was also something that was an issue that we had a concern with regard. So what we decided was we started the patient on antibiotics. We thought we'll take up the patient after an antibiotic course, at least for about 4 to 6 weeks at least. Now, we started the antibiotic around 2 to 3 weeks post. The patient had told that before surgery, she wanted to go home and then come back. So we thought we'll just take a CT before the patient is let off, and then we'll plan the endovascular procedure accordingly by the time the patient comes back. And to our shock, actually, we found out that the aneurysm had almost doubled in size in the 3 weeks that the patient was actually on antibiotics. So now the neck was actually almost encompassing the entire arch till the brachiocephalic vein. The size was almost little more than double. So with this, the options of waiting was actually not possible. So this was a size at the time of our final decision-making time. So our initial plan was actually, along with surgeons, was to do a zone 0 debranching. So we would place a TVAR stent graft across the arch after the surgeon places a bypass into all the 3 vessels. Now we wanted the left subclavian bypass as well, because the patient already had a left AV fistula for dialysis, through which the patient was already ongoing dialysis. So we wanted this subclavian anastomosis as well. So this was the working plan prior to our start of procedure. So the surgeons actually operated, and then there was the second shock that when they opened the entire pericardium, the aortic wall, everything was very inflamed, very friable. They could not take their sutures very well, and they could not actually dissect posteriorly into the origin of the subclavian. So at the time of surgery itself, they said that they could only put in a bypass from the ascending aorta into the right brachiocephalic as well as the left common carotid. So this was what was the initial plan and what we had initially planned on the day of our procedure. But this is what we finally ended up. So after surgery, this bypass was there. There was a bypass to the left common carotid. So post this, our plan was to put in a TVAR stent graft as was planned. And then we had to occlude the subclavian because otherwise that endoleak would be there. So we thought we'll put a plug here. And then another additional problem was, then once we are plugging this fistula is of no use. So the concern was, because and the left upper limb will get its supply only via the steel from the vertebral artery. Because of the existence of this fistula, there may be steel through the fistula, and the limb will go for ischemia. So just before procedure, our final plan was put a TEVAR stent graft, then put a plug to occlude the subclavian artery. So the flow will be in this direction. Once this is done, percutaneously, what we did was we put sutures through the skin under ultrasound guidance around the superficial vein in order to occlude the dialysis fistula. And then we put a temporary catheter in the left femoral vein in order for the patient to carry out dialysis. So that was the plan. So this was the procedure. So this is initially we took a right brachial artery access. We have put in a vertebral glide catheter and taken the angio. So this is through the bypass graft that was placed, the ascending aortic bypass that was there. And then we have put in the catheter into the ascending aorta. And then we have kept a wire as a marker for the ascending aorta landmark. And then through the femoral cut down, we have put in a sheath. We have put in a pigtail catheter and taken the initial run. So this is the initial run that shows the aneurysm sac here. So this is the catheter and the wire that was placed as a marker for the proximal deployment of the stent graft. So with this wire here, so this is the wire as a landmark for your ascending aortic bypass. And finally, we placed a medronic, the aortic ascending aorta diameter was around 30 millimeters. So we have kept around 20% oversizing. So we have used a 36 to a 32 millimeter tapering medronic valiant stent graft across the aneurysm sac. And this is the angio post deployment, which shows no filling of the aneurysm sac and filling of the neck branches. Once that was done, we took a left brachial artery access, and because the caliber of the vessel was 8, we used a 12 plug. Sorry, we used caliber was around 8 to 9. We used a 12 plug. So this goes through a 7 French sheath. So we used a 7 French destination long sheath through the brachial into the subclavian, and then we have placed a vascular plug to occlude the subclavian and to prevent any endoleak into the sac. This part, this is not our patients. This part, what the final procedure that we did, I did not have the image. So generally what we did was the patient had a fistula with a superficial vein that was here. So we took a large 10 silk catheter with a large semicircular dimension sized needle. So this can be seen on ultrasound guidance. So under ultrasound guidance, through the skin, through the undersurface of the fistula vein, we have come out through this side and put ligages at 2 or 3 sites to occlude the fistula as a temporary procedure. Now I'll take you through a case of a PARTO. So quickly I'll run you down through the rest of the cases also. So this is a 58-year-old male, cirrhosis DCLD. Patient had multiple episodes of bleed. Presently, the patient had evidence of hepatic encephalopathy, for which CT was done to look out for shunts. So we saw a gastrorenal shunt with multiple varices, but there was a large mucosal varice as well. And the time of our procedure, there was no recent evidence of any melena. So this case is just to highlight in practice what what we are doing different from Chitra at present. So generally what we do is we go through the femoral axis. We put a long sheath, the sheath that we now use. Initially, we were using the Cook shuttle sheath, which we have found is a bit difficult to navigate deeper into the vein. So now we have actually shifted to the hydrophilic coated destination sheaths, which even 8 French will go very smoothly, relatively smoothly when compared to the Cook sheath deep into the varices. So this was pushed into the gastric varices, and the procedure remains the same. So this patient had a bilateral phrenic vein as well as some lumbar veins, which was selectively cannulated after passing our long sheath using a microcatheter, which was embolized using mixture of gel foam and PVA. Before we put in the sclerosant, we have placed a vascular plug. Now this we have actually used a AVP device, AVP. Now this was also one of the initial cases that we have done. Lately we have actually our hardware. I'll just run you down what are the changes that we are now using in our place. So generally we use a initial 6 French sheath through the right femoral. We use a Cobra catheter to go into the left renal vein, and sometimes whatever catheter we generally use is now a 4 French catheter to the at least till this level of the gastrorenal shunt. Once what we initially itself use an exchange wire, because if the Cobra is not going deep into the gastric varices, we'll exchange at this location itself, because usually the exchange wire will go very smoothly deep into the varices. And then over the exchange wire, we'll push in a 4 French vertebral glide. Usually the 4 French vertebral glide will go much more smoothly, not the 5 French. So we use a 4 French vertebral glide catheter. And once the vertebral glide has reached deep into the varus, we'll change it for an Amblat's extra stiff. Over the Amblat's extra stiff, we'll use a destination sheath. And then after the destination sheath has reached into the till this level, we'll pass a microcatheter deep into the varices. And then finally, we use a ceravascular plug that is deployed in the lower part in order for shunt occlusion. The advantage of Cera over Ambulats is generally that the size of the required sheath is relatively less when compared to the Ambulats. This is a relatively light device, so even a 8 French will accommodate up to 20 mm of your ceravascular plug, which will suffice in most cases. And in general, in our practice, we have not had any specific issues with ceravascular plug. So these are things presume that most people are aware of. So generally for gastric varices, the primary option is BRTO. If the patient has hepatic encephalopathy, again, the option is BRTO. If patient has associated congestive related symptoms, you need to couple it with TIPS. And if there is any uncontrolled esophageal varices that's bleeding, then again, TIPS along with BRTO is an option. If both encephalopathy, ascites, both are there, then BRTO probably may be the only option that can be done. Now, I think I'll have 5 more minutes. I'll just quickly run you down through these smaller cases. So this was a 55-year-old female who was a case of a CA ovary post-surgery, post-chemo, and then surgery for pelvic excenteration with removal of bladder because of infiltration of bladder as well as distal ureter. The patient underwent a ureteric reimplantation with the iliac conduit. So basically the ureters were anastomosed to a part of an ileum, and then that stoma was opening into the skin. Actually, on follow-up, the patient was found to have a leak from this part of the right ureter. So in this part, there is a leak of contrast that was then tracking into the presacral area. So a re-exploration surgery in order to cut this part and then reimplantation into the iliac conduit was deemed very difficult. So what we did was we actually the other treatment that can be done is actually you need to divert the urine from the side from this part. You keep this part where the leak is there. You keep that part dry for the ureter to heal, and then automatically the urine will drain into the conduit and then come out. You will require long-term keeping this part dry. So the patient was actually referred to us for this purpose. So the option was either to put in a degestant from above down, but the problem was then again through the skin you have to puncture the kidney and then put a degestant. Also, the lower end of the degestant would then remain in within the iliac conduit. So removal of the iliac conduit on a the degestant later on would require an endoscope to be passed through the stoma through the iliac conduit, then to pull it out through this part. So what we did was through the percutaneous stoma, we passed normal vertebral glide catheter and wire, a thermo wire. And then in CT, we knew almost approximately it was at the level of your upper border of sacral ala, at the site of your ureter reimplantation into the iliac conduit was there. And because it is post-surgery, this part will not move. So under fluoroscopic guidance, we manipulated the wire into the ureter proximally. And then because keeping it dry was one issue, and second was this part of the catheter had to come out through the stoma. So we have used a 45 centimeter PTBD internal external catheter. So it had multiple holes all throughout. This is about 45 centimeter. So the tip would actually come out and the holes would be all throughout the pelvis till the upper part of ureter. And you have a marker here. So the defect was somewhere here. So this is for a ureteral urine diversion. Next, I'll quickly run you down through a case of a splenic artery pseudoaneurysm. This was a 32-year-old male who had an acute on chronic calcific pancreatitis. CT showed a pseudoaneurysm from a tricky location. So this was a proximal splenic artery right at the trifurcation of the celiac trunk. So this was the angio appearance. So this was the aneurysm, the splenic artery, hepatic artery. So the treatment issue was because this was right at the junction. Any coiling at this part would entail that the coil may prolapse into the hepatic artery or branches of the celiac trunk, occluding it. So what we did was actually initially we tried through the femoral route. We passed a long sheath here into the celiac level of from the aorta. We passed a 1/4 wire with a coronary balloon. So this was a 5 mm medronic coronary balloon. I think it was 15 mm length. So this was a coronary balloon that was initially passed through the femoral route. We initially tried again through this sheath itself to pass a microcatheter into the splenic artery through the side of the already placed balloon and wire combination. And then we thought we'll inflate and then start putting the coil. Our issue was when we were putting the coil and then withdrawing, this was not stable and the microcatheter actually completely collapsed out of the celiac trunk. Luckily, this was a detachable coil that we were initially putting. So then we changed to this coiling catheter from the uh, radial side. So this was a radial vertebral guide that we had placed and the microcatheter into the splenic artery. The balloon was kept inflated and then coiling done from the radial. So this is an example of a coronary balloon assisted coiling. The other option of doing a percutaneous thrombin probably may also have been an option, but this was also done, I think, around 2.5, 3 years initial time. At that time, thrombin as an option was relatively, we were not confident in using thrombin at this particular location, that too in a patient of pancreatitis. So this is a patient of chronic mesenteric ischemia. So this was the initial angio that showed tight stenosis of the celiac origin. There was an occlusion. This is post-crossing angio. So this was an occlusion involving the SMA. So this again, initially we tried through the femoral route, but naturally because you are taking a U-shaped curve, your deployment of stents, balloon, it is not that easy. So we have shifted to the radial. So this for this patient, we have actually taken a brachial axis. So initially we have cannulated the celiac trunk and then passed a 1/4 wire and then initially balloon dilated it, followed by stent placement. So this was a hippocampus medronic 5 mm stent that we have placed after a guide sheath was placed till the celiac ostia. And then we have proceeded with cannulation of SMA. Again, the system continues wherein we have used the same 5 mm hippocampal stent for SMA. And this is the final angio with the SMA flow. It is important that you counsel these patients to be on antiplatelet or your dual pathway inhibition. Actually, for this particular patient, we had actually started, this was the time when dual pathway inhibition was being discussed a lot. We actually started the patient on dual pathway inhibition. Around 6 to 7 months down the lane, he stopped taking roxaban and icosapent because the cost that was involved. And about, I think, 9 months, 1 year back, he came back with occlusion of the stents. So I think it's also important that you not only counsel with regard to the requirement of the drug need, but also the cost factor also becomes important when you're doing these cases. Also, this was a case of a 64-year-old male, a facial artery aneurysm. This was a CA oral cavity that underwent punch biopsy as well as, excision biopsy with the site getting infected. This patient was actually referred from a hospital outside in a emergency situation wherein the patient actually reported to the casualty spitting out blood. So if you see the aneurysm was, the wall of the aneurysm was seen almost at the level of the oral cavity on the surface. The patient was restless, unable, continuously there was blood oozing out. So the surgeons again, because of issues with regard to the surgical aspects, could not take up the patient immediately for surgery, and the patient was immediately shifted to our cath lab. So the anatomy here was a tortuous course here and the aneurysm at this level. So this was the angio, so this was the aneurysm here. So we had great difficulty actually cannulating this. On top of that, the patient every 1 to 2 minutes he had to slightly sit up and then spit out the blood. In between, we were also very doubtful whether to suction also, because this was almost at the surface. So the ENT surgeons actually kept a pack within. So this initially, when we started, this aneurysm sac was completely seen. Then in between, because I think the sac was, the pack was being kept, slight thrombus formation was seen, but still filling. So because our system was actually not stable, we could not get the microcatheter inside, and getting a long sheet there, time may be consumed. So actually we were planning to drop the procedure and shift to an OT. At that particular point, my technician actually told, sir, will this Ravi catheter help because of the curve? So I thought, okay, we'll just give it a try. So this was a 4 of Ravi catheter. We used an MG, I think MG2 was used. That swiftly went and sat at the origin of the fascial artery. And then we pushed the microcatheter in and then embolized it using glue as the embolic agent. So this is the glue cast that is seen in the final angio. So I think it's 4 o'clock. So yes, sir, is it okay? Should I stop or shall I continue?
Sir, you can continue, sir.
Just one more.
Okay, then we can continue.
So this was a case of a renal transplant. So this was a 49-year-old male post-transplant. I think it was around day 9 that the patient started developing worsening of renal function. His Doppler showed parvostardus flow. So naturally there was doubt, because renal output was also reducing on a daily basis. Naturally there was to be a renal artery stenosis. So we did not do any imaging at that time because already his renal function was deteriorating. So we directly took the patient for an angio. So this was after placement of a Balkin sheath, 6 French Balkin sheath from the left femoral artery, and the angiogram that shows the tight stenosis at the site of anastomosis. So because there was a compromise in the renal function as well as renal output, and this was in the acute stage, what we initially did was we ballooned this segment in order to increase the flow. But the issue with these is that these are likely to recur, and true to the fact, around I think 4 weeks time again, that the deterioration of renal function as well as output occurred, and eventually as a second sitting later on, we had to stent the patient, and now the patient is on antiplatelet at present. So from here we have actually stented. So again we have used a 7 French Balkin sheet. We've used a 6 French Balkin. We have used a 7 French Balkin, a 6 French guide catheter to get it across, and we've placed a I think we've used, I believe, a Herculink or an Omnilink. The abort renal stent is what we have used. We have used a 5 mm stent. 5 mm 29 mm stent is what we have used in this particular patient. Okay, thank you.